Good afternoon and welcome. Thank you for joining us today. My name is Samantha, and I am the Director of Member and Partner Services for the Florida Association of ACOs. We are excited for this opportunity to present to you our next installment of our webinar series, What's Hidden in Your Claims Data Could Save You Thousands, presented by Suresti Health. Before we get started, I'd like to go over a few items so you know how to participate in today's webinar. You will see a user control panel on your computer desktop. You can listen in via your computer speakers, or if you would prefer to join over the phone, just select the arrow above the mute button and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenters by typing in your questions into the Q&A tab. You may send in your questions at any time during our presentation. We will collect these and address them during the Q&A session at the end of today's presentation. With that, I'm going to turn the presentation over to Dirk.
Great. Thank you very much, Samantha. Thanks for the opportunity. Thanks for taking the time to join us here today. My name is Dirk Sonksen. I'm one of the co-founders and the CEO of Suresti Health. So maybe just in terms of our panelists, I'll have them introduce themselves shortly, but at a high level, right, we're going to take about a minute, have the panelists introduce themselves. I'm going to then walk you through a presentation that will be no more than 8 minutes to kind of set the stage and kind of talk about dementia in the Medicare population. There'll be some things in there that may be provocative, and then we'll unpack them in the panel discussions. And we'll be sure to leave about 10 to 15 minutes at the end for questions. So then without further ado, could I ask maybe going from left to right, and we'll start with Bart, then go to John, and then Nicole, and maybe just do a quick introduction, and then we can get right into it. Thank you.
Thanks, Dirk. Hello, everybody. I'm Bart Asner, primary care physician, and I was the founder and CEO for nearly 30 years of Monarch Healthcare, an IPA model physician group in Southern California. I also served twice as the chair of APG, America's Physician Groups, so I've got a lot of experience in this field.
Hi, everybody. Thank you for joining us today. I'm John Mock. I'm a physician and geriatrician, currently serving as the Chief Medical Officer of Suresti. Spent 10 years at a multidisciplinary dementia clinic at the VA. Then for the next 25 years, really worked on the business side of medicine, serving as Chief Medical Officer for special needs plans, to Medicare Advantage, long-term care Medicaid, as well as being the Chief Executive of large special needs plans. Most recently, I'm also the chair of the board of the John A. Hartford Foundation.
Hi, everyone. My name is Nicole McPherson, and I am the Director of Coaching Services here at Suresti. I run our team of coaches, as well as have coached hundreds of caregivers through our program.
Great. And maybe just to go back, so I already said who I am, but I'm an engineer by training. Both of my parents had dementia. Both of them died of the disease. This is one of the motivations for the company. I'm an entrepreneur, so I've spent my whole career, tackling, I think, important and interesting healthcare problems. I'm really excited to talk to you today about the impact that is possible to have on people with dementia. So let me take just a few minutes and walk you through, at a high level. I want to take at least one slide to sort of share with you what Suresti does. So we are solely focused on patients with dementia. We've been doing this for almost a decade, working in Medicare Advantage, and also now with accountable care organizations, demonstrating the ability to improve quality of care and to reduce costs of care. Right? You'll hear words caregiver enablement talked about, right? So we'll unpack for you how that's different from caregiver support. You'll learn a lot today about, how do you actually keep people out of the hospital and the importance of detecting a change in the patient's condition in the home. We do this through a tech-enabled monitoring model. We offer a turnkey solution to our partners, and we have clinical studies data that actually supports our assertion of being able to save money. So let me sort of jump right into it. First of all, we'll talk about dementia. We'll talk about maybe why it isn't a condition that's typically identified for cost savings. But it's a big problem, right? It requires actually involvement of the caregiver. So if that doesn't sound familiar, this is really going to be one of the key messages that we'll try to bring to the table. It is considered a national priority. CMS through CMMI has stood up a model called GUIDE that actually is aimed at dementia care. And the problem is going to get worse. Baby boomers are continuing to age. There's a shortage of primary care physicians, and a significant proportion, as many as 50% of patients are actually not diagnosed. So the good thing is that there are things you can do, right? Historically, people said, what can I do? But there are interventions out there that have proven cost savings and have other benefits. So if you're also taking, downstream risk from, let's say, an MA plan or something, right, you can really improve your risk adjustment factor accuracy and other things. And then at a high level, we guarantee our success. And so you can ask more questions about that. We're not trying to make this an infomercial about the company. I just want to give a little bit of background. We did some years ago commission Milliman to look at Medicare Advantage data in dementia, and I just wanted to share some of that. It turns out that through the Milliman analysis, right, they reported that 27% of all Medicare hospitalizations were incurred by people living with dementia. And 21% of the total cost of care was attributed to people with dementia. The typical prevalence is about 8.5%. And unsurprisingly, the costs are really high, right? The cost multiplier is typically 2.5 times what your average revenue would be for a patient, so about $2,800 per month. So the challenge with dementia, of course, is we're not really thinking there's a solution. So as a result, it's not prioritized. And we'll talk about how the costs are sometimes invisible. This is sort of the title of the webinar, but if you looked at the costs for people with dementia, you would be astonished at how expensive they are. The reason people with dementia are so costly is they really can't self-manage. It really comes down to that. So if somebody can't self-manage, they can't engage in traditional clinical programs. So you'll find very few or zero people with dementia who are actually effectively engaged in anything that exists today in care management. So that's a really important takeaway. Many times we get people who don't really believe that, and then they kind of take a look and say, oh my, you're right. There's really nobody effectively engaged because the person can't self-manage. The costs are not driven by the dementia alone. They're really driven by unmanaged chronic conditions. And as a result, people with dementia have lots of chronic conditions. 42% of people who have a dementia diagnosis have more than 5 chronic conditions. The key thing is the family caregiver is usually available and willing to help, but there isn't typically a way to engage them, right? So this is really how we're going to talk about an effective way to impact outcomes for people with dementia. Both health plans and ACOs are not really able to engage family caregivers, right? They're usually able to engage patients if they can self-manage, and this is a little bit of a blind spot. So we'll say more about this. And there's a study that was published some years ago, and if you go and then you take all the dementia costs, you put them into one bucket, dementia is the second most expensive condition in Medicare, and this is actually a fee-for-service analysis. This is not commonly known, and we're going to unpack this a little bit, like why is this not well understood? And you're going to hear from some of our physician leaders, their experiences in some of the organizations that they led, right? The key thing to realize is that now effective solutions exist. The GUIDE model has established sort of an evidence-based standard for dementia care. That's super exciting. So you can point to CMS and say, look, this is what they recommend. This is something they've been studying for almost a decade. And as a result, they've decided that they're willing to reimburse for that. Maybe just to highlight another way to look at this, at least in studies that we've done, we talk about the dementia multiplier. So what you see on this slide on the vertical axis are hospitalizations per 1,000 patients per year. And what you see in light blue is the hospitalization rate for patients who have diabetes or COPD or CHF. Now what you see in purple is what happens when dementia is comorbid with diabetes or with COPD. And you look at this and you say there's a 2 to 3 to 4. We've seen it as high as 5x multiplier when you look at the hospitalization rate. So we're going to unpack why that is. If you look in your own claims data, you will find this, I guarantee it. And then in green, you'll see what's possible with an intervention like what Seresti has. So it is possible to really largely extinguish these avoidable hospitalizations, which, by the way, are also very harmful. Right? If you have experience with this, sending somebody with dementia to the hospital is traumatic. Right? It accelerates their cognitive and functional decline. So there is this thing called the guide model. We'll say more about it, but this is really what makes this interesting for accountable care organizations. Under the guide model, CMS is paying a care management fee to a guide participant. Seresti applied and was accepted into the guide program. So we're a participant. Right? So at a high level, we would look to partner with ACOs to enroll your dementia patients into the Seresti guide model. Right? We get our fees paid by CMS, and you get $6,000 to $8,000 in savings per patient, which of course, you got to multiply by your percentage of upside risk. But it's significant. So for a typical accountable care organization, right, this is the net savings that you could achieve. And net means, this has been multiplied by the percent upside in the track. The total savings are higher, right? So these are really for organizations that are already sort of making money, and this is just how much more money they can make. But you can see, based on the different tracks, if you have 1,000 attributed dementia patients, which would mean your ACO is like 15,000 patients, these are the types of savings that are possible, right? So at some level, this is an opportunity to improve care, improve the amount of shared savings, and to do it with no risk, right? We'll talk about this, but we at Seresti also kind of protect your downside. We guarantee that the increase in medical expenditures that come from the guide model will be much less than the cost savings we achieve. So you'll have a net benefit. That's all baked into these numbers. So that's really all I wanted to share at a high level. I'm now going to stop sharing, and we'll go to a panel discussion, and we'll have fun for the next sort of 35 minutes, and then we'll stop and we'll take some questions. Okay, wonderful. So let's kick this off. I've said a lot, but I want to really have the two physicians here comment on my perspective that dementia is really, really expensive, that it's a top target for cost savings. So maybe starting with you, Bart. You were at Monarch, right? What's your experience with people bringing dementia to you saying, hey, Bart, we should focus on this?
There is no experience with people bringing dementia to me to focus on. We had many, many thousands of seniors at global risk, and we were a pioneer ACO, one of the first ACOs. And over nearly 30 years, I never heard any of my very sophisticated clinical team and analytics team tell me, hey, do you know that we should be focusing on dementia? Do you understand the costs of dementia? So the numbers you showed, and they're obviously supported by good data, are shocking to me. Yeah, we focused on the usual COPD and CHF and diabetes and kidney disease. Dementia never came into the conversation. And we really missed the boat over all those years. Today, it's so important to reduce cost of care. And I think many of us have done a lot of good work in the traditional areas, as I mentioned, but we're always thinking, what's next? What more can we do? And dementia is a great opportunity that really has not been taken advantage of by most medical groups, I would say. In fact, probably any medical groups who don't know about the data that you showed, because to this day, my organization does not know what you showed on those slides.
John.
Yeah, my experience is very similar. Again, 25 years of working with large health plans and ACOs, looking for the highest risks. And, it's the goal has always been, so my career's all been around high risk populations, identifying, because I do believe there's a lot you can do, and we'll talk about dementia specifically. But the search for who are the highest risks for preventable hospitalizations, spent a lot of time with data scientist teams, working hard to pull through claims, looking for things. We early on adopted a philosophy of multiple chronic diseases and not individual diseases, as Dirk showed. That's a big driver. You can get really much more tight around who the smaller population drive the higher amount of cost, and you can get much more efficient on that. Dementia never came up. And I think, you had on your slide, Dirk, that it's because there weren't any solutions available. That may be true. I actually think it's harder than that. It's just because you should still be able to see it in the claims, and it's not popping up on the so-called target list. And I believe it's the way the claims are pulled. When people go in for hospitalization, typically, and we'll talk about this, it's the exacerbation of their underlying other chronic diseases, not the dementia. So it's not coded as dementia. So if they have a 5-day, 6-day hospitalization and a sniff stay after that, none of that's coded as dementia. So it's hard to pick up. So I think this learning, and I'm a little embarrassed, I'm just learning this now after all these years, I think is extremely important. And so we find out there's something you can do about it.
John, I think you made a really good point in that we look at these admissions as COPD, CHF, combinations of these things, and the multiplier effect of dementia was not anything that was ever coded on those admissions. They were coded for the major diseases, not for the underlying dementia. So it's another reason we really weren't aware.
Yeah, as many of people on the call have dealt with people with dementia, it's not a stretch to understand why there might be this multiplier with dementia on top of everything. People with heart failure or infection will say, I have a fever, I've got chills, I'm short of breath. They can self-report what's going on. People with dementia, that's much more problematic and typically presents much more subtly, real, but much more non-specific symptoms like agitation, restlessness, sleeplessness, or the other, more somnolence, appetite changes. Those are the key indicators that usually don't resonate urgency or alarm or action or stimulate action for a lot of people.
Which gets to the point of the cost of care is so much higher because we're intervening much later in these patients with dementia. And I'm sure we'll talk more about that.
I think one of the things just to highlight, when you can find the cost in claims data, but you have to look in all of the diagnostic fields. So if dementia is not in the first or second field, which is sometimes what people do, they look at what's the primary reason for admissions. If dementia is, 5, 6, 7, 8, 9, it's present. And our view is that the hospitalization probably could have been avoided if you understood it was driven by dementia. Right? I think this is a point that we'll make further in the presentation. But there's some unique things about dementia that make it a little bit more difficult to understand, right? So when somebody shows up with congestive heart failure and it's caused because of inability to self-manage, that doesn't get recorded as the first or second diagnosis by the physician in the hospital. I think that's one of the reasons it's hidden. It can be found if you know how to look for it.
Yeah, and most of the inpatient care may be provided by hospitalists these days. They're dealing with the major medical problem and not focused at all on the dementia. They're dealing with, how do I get this patient with the infection or CHF, whatever it may be, better, well, and out of the hospital. And dementia is not something that they're really focused on.
Yeah. So, we've talked about the high costs. We sort of alluded to hospitalizations, but maybe, John, I'll start with you. But could you just sort of talk about why is this expensive? Right?
Well, as in all high-risk populations, it's really, you look for the high hospitalization costs. That there may be some subsets around drug costs that's more about the drug costs, but in the people that we serve, older Americans who are at risk for dementia, it's almost all hospitalizations. And when you look at ambulatory care sensitive condition hospitalizations, which are preventable by definition, large percentage of those are preventable. So and I just, before I forget, Dirk, it's not just a cost issue. The clinical consequences of getting sick, being put in the hospital, to the patient, where they get more agitated because of the dementia and new surrounding. They might need more sedation. They might actually get restrained. Nursing homes tell me that patients from the hospital come to them with pressure sores, not the nursing home causing the pressure sores, because of all sedation and restraints. And then not to mention the caregiver burden. And so this is all really well documented, but it's really important to point out it's not just about costs, but costs are a key thing here.
And I would add to what you're saying, John, that patients with dementia who end up in an ER are almost certain to be admitted. Let's face it, that poor ER doc is trying to get the information from a patient with dementia, and they're not going to send them home. It's too risky from the point of view of an ER doc. For most ER situations, the quickest way out of the ER is into the hospital anyway. And for a dementia patient, it's multiplied 10 times.
Yeah, and that's not the fault of the ER docs. I mean, these people
No.
look sick, and it's really hard to tell what's going on. And you need some time to evaluate that, and you don't have that luxury in an emergency room. Really good point. I think I'd go on to say, Dirk, on the hospitalizations, and we mentioned the drivers are the exacerbations of underlying disease or superimposition of things like falls or infection on top of a very sensitive host, if you will, with very limited ability to fight off those things. Those are the drivers of the hospitalization. And as Bart was saying, those symptoms helpfully appear 2 to 3 days ahead of time. If you look back and do chart reviews, which we've done, you can see indications. And, importantly, there's somebody else in the home typically who sees it and can alert us. And I think that's something we can really work on and do work on.
So you're kind of really getting to the next topic, which is how do you prevent the hospitalization? And I think, John, you were talking about, identifying a changing condition in the patient. Maybe you can say a little more. You have a great story, right? That maybe you can tell from your early days as a geriatrician.
Well, yeah. I mean, I used to make nursing home rounds, and people were relatively stable typically, but we came upon this one woman on rounds one day, and she was standing on her bed, clutching her purse, screaming, and which was unusual behavior for her. And, it would have been easy to say, well, that's her dementia. We should sedate her, give her a psychotropic, anti-anxiety medicine, something, medicate. Turns out she had a urinary tract infection, and this is well known, and Nicole's going to talk about this. And so in a non-value-based setting, all the incentives would be sent her to the hospital, and then all this bad cycle happens where she gets sedated and gets treated and overtreated probably, and then comes back with pressure sores. In a value-based model, you identify it early, you jump on the underlying cause, you can prescribe oral antibiotics, you don't need IVs, you make sure they're hydrated orally, and sure enough, within 36 hours, she was fine. And totally presented that disaster, costly and personally disaster hospitalization that can happen. So just to elaborate on that a little bit. Yeah. So one of the things that is a key thing here in dementia is leveraging the caregivers because they really, and we try to do this in all our care management programs, is try to find some kind of early alert system. There are a lot of technologies out there, none of which are going to be broad enough to capture the kinds of things that happen with dementia, in my opinion. I'm not an anti-tech guy. I just don't think they're really positioned well there because they're more about blood pressure or individual symptoms and signs. They don't capture necessarily the changes that we see in people with dementia. If you find out those things, leverage the caregiver, basically invite her in to be part of the team, coach her, typically her. And how to handle that, how to recognize and handle it, act on quickly, you can in large part reduce these hospitalizations.
And by reducing the hospital,
can you speak to care management teams being able to detect changes in the condition? I mean, this is, you guys were super at this at Monarch, but this is probably something that would be challenging to do with a traditional approach.
Yeah, I mean, our care, we had large numbers of care management nurses who worked with our medical directors, and they were often on the phone with the patients who had COPD and CHF and diabetes to make sure that they were doing the right thing and taking care of themselves. And they established a relationship with those patients where the patients would often call them. Well, in the case of dementia patients, you can't establish a relationship with the patient. You don't get the information from the patient like we do in the non-dementia world. And if you have a caregiver who is not really engaged and knowledgeable and working with you, you're not going to be able to intervene early. And as John said, if you don't intervene early, then you do end up with patients that go to the hospital that often could have just been dealt with at home, perhaps a phone call to a PCP, a change in medication. There's so many simple things you could do. The nurse case manager might have had some advice. And we just really missed the boat in the dementia patients because we really weren't able to work with engaged caregivers.
Typical care management teams do outbound calls to check in on people. They might stratify and increase that frequency, but you only have a couple of days once the event starts. So it's only if you get lucky to have them call in that day, is a typical care management outbound call-in approach going to work for this.
Yeah. So this then, right, begs the question, like, can you effectively engage a family caregiver? And can you use them, usually is the wrong word, but can you actually engage them to observe their loved one, share that information, and then counsel them to say, hey, this is something that, you know, you need to lean into primary care for, right? That's really the model here, is that the family caregiver is detecting a change in condition. And as you said, you got 3 or 4 days. And so if you can leverage primary care, you can avoid the acute event. Our clinical studies at Ceresti have shown reductions in hospitalization greater than 50% through this model. And Nicole, so you're going to tell us the secret sauce, right? Because we've said if you can do it, you can save money, right? So tell us how at Ceresti we're actually engaging family caregivers, right? And maybe just remind people your role at Ceresti and, you know, what team you manage, and maybe then go into the details.
Right. Thank you, Dirk. I'd be happy to. And I am the Director of Coaching Services here at Ceresti. So I am running the team of coaches that are directly supporting and engaging our caregivers working through our program. Here at Ceresti, so we are sending an easy-to-use cell-enabled tablet to the family caregiver, who is typically an adult child or a spouse. And the tablet has a really comprehensive program aimed at teaching those family caregivers how to best care for their loved one. So over many years, we've developed thousands of educational modules that center around what the best practices are for managing all aspects of dementia, as well as some of the other conditions that we've talked about today. So we're really using analytics and predictive models to personalize the workflow content for each caregiver. And we base that on assessments, claims data, and engagement patterns. And in order to support each caregiver and drive really great engagement, we match the family caregiver with a dedicated care navigator. Here at Ceresti, we call them coaches. And again, this is the team that I run. This coach works really hard to build a trusting relationship with the caregiver and support them through all aspects of the program. So each coach brings a really unique and diverse background to Ceresti here. They have experience in different aspects of dementia care that could be related to social work. Maybe they've worked in assisted living or memory care. And a lot of us have a lot of personal experience caring for someone who is living with dementia. So our real goal is to improve that family caregiver's knowledge, skills, and confidence about how to best take care of their loved one, as well as focusing on improving that caregiver's ability to engage the healthcare system on behalf of their loved one. So what we do at Ceresti is a little bit different and unique, and we call that approach caregiver enablement. We're really going further than your typical caregiver support. We are really working to engage family caregivers in our program for more than 40 minutes a week over many months. So we get really great engagement and really close relationships built with our family caregivers, that they share a lot, they trust their coach, and they know that there's somebody there on the other end of the phone or the message that they've sent through the tablet. Each day, we ask the caregiver to complete a daily assessment on the tablet, and it gives them an opportunity to report what they're observing in their loved one. So we ask them to indicate any behavioral, medical, or other concerns so that their coach can use that information to support them through any issues that may come up. So we use that daily assessment and those coaching interactions to detect those really crucial changes in condition in the patient. So all of those daily assessment results are triaged on our end, and that results in a prioritized list of caregivers for each coach to follow up with and offer support to. When appropriate, we encourage those caregivers to actively reach out to their loved one's physician. And if our client is a provider, we may send alerts directly about a possible change in condition regarding their patient. In my many years of experience in personally coaching many caregivers through our platform, we've had such great success in engaging family caregivers in detecting those changes in condition following this approach. And we've helped so many people through this journey that can be a little bit scary and intimidating. but they really want to help their loved one have the best experience and, the best quality of life as they are living with dementia.
And John talked about urinary tract infections, but I mean, can you just maybe anecdotally share, how common they are, how impactful they can be if they're not managed, but how relatively, I don't want to say easy, but the success we've had in highlighting that as a possible cause for a change in behavior.
Right. So often, these family caregivers don't know that these UTIs present differently when we have someone living with dementia. We typically expect more physical symptoms. Say for an adult child, they might expect burning sensation, foul smelling urine, things like that. And the person or their loved one might not be able to tell them that it hurts, but they might not have slept all night. They might have been experiencing a total change in personality. Maybe the most sweet and docile mom is now just agitated and angry and saying, bad words that she never says. And the caregiver might just think, well, this could just be dementia or maybe a bad day. But if they share that information, say, for example, in the free response section of our daily assessment, our coaches are going to hone into that change in condition. And I myself have done it so many times and have seen those UTIs identified where that caregiver had no idea to look for that or to ask for a urine test to be done to rule those infections out. So it happens, it's probably the most frequent change in condition that we can detect, and yet the most impactful because we can get it treated right away.
I think this highlights one of the challenges of dementia, right? That the symptoms are masked.
Mhm.
And I think, John, you talked about this a little bit earlier, right? But isn't this the unique thing about this condition is that you have to observe something and then, somebody has to do the detective work to say what's causing it. But is it fair to say that you could have a skin infection or an unmanaged, let's say, chronic condition or UTI, and it could all show up as a change in behavior?
Exactly. The same, yeah, they could all result in the same behavior as somnolence or appetite change. So they're very they're very non-specific, but what's important, they're very sensitive. So if you see that, something is going on. And so a lot of the work that Nicole does, and she probably should speak to this directly instead of me, is like understanding with the caregiver what their normal patterns are, which are going to perturbate a little bit over time. They're going to vary a little bit. The caregiver has the absolute best sense of everybody more than any technology of whether this is out of the ordinary. And then Nicole goes on to coach them what to do about it, give them confidence to engage, teach them how to work effectively with PCP so the PCP is not overwhelmed with all the possibilities because it is non-specific.
I think that point about the PCP being overwhelmed, it's very difficult for a PCP in an office visit to figure out what's going on with a dementia patient. And so I really have tremendous sympathy for the PCPs who are trying to do that without the benefit of the early intervention that we can do through Suresti and the information that can be provided through an engaged caregiver.
And go ahead, Nicole.
Yeah, if I could speak to these family caregivers want to help their loved one. They have the most skin in the game, so to speak. And a lot of times a patient, a member could show up in a doctor's appointment and in that moment they look fine. They can have a great conversation. They might answer questions that they normally can't answer. So here at Suresti, I can't tell you how many times we've helped those caregivers get the right and accurate information to the doctors so that they can make necessary changes and tweaks. And those caregivers are so thankful. They aren't coming from a place of fear or unknown or, well, I don't want to upset my loved one by saying the wrong thing. It's really powerful to educate and empower these folks and then see, take the training wheels off and say, you can do this and you're not alone. We're going to be here to support you through it. But this is how you achieve this. This is how you take the best care of your loved one. And then it's like this light bulb moment and they see that they can have a little bit of control against something that feels so big and hard to manage.
So, Nicole, not all of the things that a caregiver shares with us result in us reaching out to the PCP, right? The vast majority of things that caregivers struggle with are handled internally,
Yes.
right?
Mm-hmm.
So can you speak to that? And I think, this also takes a huge amount of burden off the primary care physician because they're in a perfect world dealing with medical issues and not, how do I access resources or what do I do with my loved ones incontinent, right? But can you just speak to sort of, where most of the coaching occurs? Because we've singled out the medical stuff, but it's usually not that.
Right. Well, as you can imagine, knowing dementia, a lot of the symptoms are behavioral, and you could see anything from repetitive questioning, sundowning, wandering, agitation, and all of these symptoms are really important to address and understand and know how to interact appropriately, but they don't require a doctor teaching the caregiver. But somebody's got to teach the caregiver how to do this so that we aren't having exit-seeking behavior. We don't have someone walking out in the middle of the night in the snow, slipping, falling, and then we're in the ER. So through the education that we offer and the coaching, we're able to train and teach these caregivers, give them tools for their tool belt. That's one of my favorite sayings. I say it all the time is let me show you how to approach this person in the most effective way. It's not going to work every time because this is the nature of the beast, but we're in most cases, if we can train these family caregivers on how to help, how to be calm, understand what's going on underneath the hood so that they know this person's not trying to upset them. And they know that there's, damage that's causing this in their brain. And again, these caregivers, it's like this whole shift. They know that they have to make the changes, but once they can make the changes, the whole dynamic and quality of life for both of them can change.
Nicole, what you're really saying is it's reducing unnecessary calls to the PCP's office because that would be where the caregiver would go first. I don't know what to do. I'm going to call the office. And I can't imagine how many phone calls must come in like that without your care team being there to be the first group that they interact with to solve those problems, which really don't require a PCP or their office.
Yeah, we're very proactive. We have very high engagement goals. We want to interact with our caregivers. We are going to reach out frequently to make sure that we are addressing any concerns. We're asking the right questions, giving thoughtful answers, supporting that on the tablet with education, again, to keep it in-house, right? We can solve a lot of these things directly supporting these people.
Let's turn to implementation. So Bart, let's suppose you're at Monarch and you actually focused on dementia and you learned about a company like Ceresti. So, okay, let's think about how to implement it. What goes through the mind of an ACO when they think about implementing, a program with a partner?
Yeah, well, we had many partners come to us with programs, of course, and to solve every disease problem you can imagine. And we first and foremost would look at that partner and see their track record and see if they were credible. Clearly, there's a build or buy question that we always have to look at. Can we build this program or is it worth buying the program? In this case, I don't think we really had the capabilities or the knowledge to do the kind of programs Ceresti has, certainly not in a timely manner. And we want to get at these costs as quickly as possible. And of course, we would look at the cost of the program. If we decide to go down that path, rather than building it ourselves, it's got to make sense that we're going to have significant savings above and beyond whatever the cost might be for us in this program. One of the things that was striking to me in your early slides was the opportunity for cost savings on the major diseases that are driving our healthcare costs. We got pretty good at all the major diseases, but the next question is, where do you go next? What's the next disease you can attack to bring costs down? It's so important for us to reduce medical costs, which are driven primarily by ER visits and hospitalizations. And so can this program truly help us to bring the costs of care down in a new disease state? I mean, not that the disease state we're talking about is new, but for us, it would be new because we really hadn't focused on it. So those are just a few of the things that we'd look at, and we would be very, very thoughtful because, again, of the number of vendors that come to us with opportunities. And this one really would check a lot of the boxes.
So John, you've had a lot of experience, even on the health plan side, looking at specific conditions and saying, do we partner, do we buy? Maybe share some of that perspective and, how obviously you might think about dementia, today. Somebody looked at that.
Right. And this has evolved over time, the market has, but certainly when I was in health plans and trying to help ACOs do this, there were some things that I just thought were core to what we did. And that was, complex care management. We had a whole nother program for people who live in the last, projected to live the last 12 months of life. That was core to what we did. But as you said, we totally missed they weren't enrolling in our programs, not for whatever reason. We didn't identify them on the front end, or we were unsuccessful to enroll them through our standard enrollment problems. And then in this one, it's really a frame shift on the intervention. So the standard care management approach that Bart talked about and I alluded to is kind of, the stratification and the engagement with the care manager who would do outbound calls, occasionally do a home visit, but it'd be periodic. Just doesn't work in this case because of you only have a couple of days to react to some of these things. So for me, whenever I saw frame shift, I then got really eager and time to market. So the speed to market, as opposed to building ourselves, given we didn't have the expertise that Nicole had. This is when I look elsewhere and look into the market and see what the potential partners would be.
Terrific. Let me change the topic here to just the guide model. I want to bring up the slide, kind of explain the guide model, and then maybe we can unpack the potential value of the guide model for ACOs. So there's just one slide that I want to bring back, and that's this one here. You can see this? Okay.
Yeah.
So, more and more people are hearing of the guide model, but it's fairly new. So not everybody has heard of it, or if they have heard of it, maybe they don't fully understand what it is. But it's largely a model, it's a CMMI model, right, where the participants can be paid a dementia care management fee for providing a dementia care program that has to meet sort of, a standard of care in 9 different domains, right? So there's care coordination management, there's caregiver support and education. So a key recognition here is that the guide model requires the inclusion of the family caregiver, right? And John, you sort of said in your experience running that dementia clinic, you were looking for how do we get to the family caregiver, and that's the biggest lever. So in some ways, CMS has recognized the importance of the family caregiver, and that's central to the program, as is the potential for some, not all, but for eligible patients and caregivers for the caregiver to receive respite services. So there is a $2,500 per year respite allowance as part of this program. That respite allowance does not add to medical costs, so it is truly just an extra payment that CMS is making. Now, at a high level, right, for the guide program, right, this is, by the way, this is only for fee-for-service patients, so if you're in Medicare Advantage, you're not eligible. But for the guide program, there's really an opportunity to take the dementia patients for an ACO and to align them or to enroll them in a guide program. And, we'll unpack a little bit why it matters, right? First of all, doing nothing has a downside. And when you partner with somebody, right, if you can get all the shared savings and not have to pay any fees, this becomes a pretty attractive value proposition. So, Bart, maybe you can just continue the conversation here, but knowing what you know about the guide model, why should ACOs care?
Well, first of all, CMMI has recognized the importance of focusing on dementia as a disease state that is costing the system tremendous amount of money. And if you're an ACO, you're trying to obviously create cost savings. And the number one place to create cost savings is in reducing hospitalizations. And yeah, everyone's doing the same types of things to reduce hospitalizations, and most ACOs are doing a pretty good job. Yeah, is there a little bit of room for improvement? Sure. But the guide model is giving us an opportunity to focus on a new disease state to reduce costs and therefore create cost savings for the ACO, and have some other organization that's a guide participant like Suresti help us to meet the qualifications under the guide system at no real cost to the ACO. I mean, that's really, really unique. I don't know many cases where someone came to me and really could prove that it wasn't going to cost me anything to get these savings. And in essence, that's really what we're doing. And I think it's going to be tougher and tougher to achieve increased savings as we get better and better at managing the chronic diseases. At Monarch and the Pioneer ACO over the years, our savings was going down relative to the benchmark each time. And that's a real problem. We had to look for new ways to intervene. And here's a huge upside potential. And again, the CMS, CMMI has recognized for all of us the importance of focusing on dementia.
John, as a geriatrician, what do you think of the guide model? I mean, you are familiar with all the elements of it and what's being required. So is this a good thing?
Yeah, I want to emphasize what you said earlier. It's evidence-based solution exists, and CMS wouldn't be putting out a program. Yeah, there's a problem, but now we've got a solution that also works. And so, documenting kind of the elements of that evidence-based clinical model, aligning payment to support that. There's a question in the chat. I looked ahead a little bit about, pointing out that fee-for-service has been doing a disservice to PCPs for these people. So that has changed. And then I can't help but get excited, like Bart has, around after working hard in 25 years, looking for incremental savings. It's a little bit of a diminishing returns thing, right? You start looking through the weeds a little bit deeper, gets a little harder to get value out of that, to do inventions. Here's a whole new population that everybody basically has missed, that is not in the standard programs, that has large savings potential. I mean, it's hard not to get excited about that clinically and from a cost standpoint.
That's terrific. And so just to go back to what both of you said, if you are an ACO and you've been achieving shared savings for years and now you're hitting some diminishing returns, this is like a new opportunity, right? You can sort of say, hey, this is a population maybe I haven't thought about or I haven't tried to engage. So that would bring some incremental savings, right? That most people would probably be very excited about.
And there's significant incremental savings.
Yeah, I so often kind of in the market, when you hear the word caregiver, there are a lot of caregiver programs out there. So it's not like caregiving's not known right now. There's a lot about caregiving. Most of that is employer-based to help the caregivers survive as an employee while they have to take care of children or parents or whatever. But this is, I care about the caregiver, but this is about helping the person with dementia via the caregiver. So it's got a different flavor to it. It's not just helping the caregivers. It's really focused on the member and the ACO beneficiary through the guide program in this case to help them better care and lower cost.
Yeah, terrific. So what I'd like to do is maybe summarize what we've been talking about. So I'm going to read something and take about a minute or so, and then we can dive into the questions. Right? But we sort of talked about why this is not talked about, and I identified that the real cost of dementia can appear invisible, right? Because of the masking of the symptoms and also the way that the data is pulled in claims, right? We said you got to look at all the records. We showed an example of a published Medicare fee-for-service study that, highlights that in that particular instance, and this is a 5% CMS sample, dementia is the second most expensive condition, right? Which is really astonishing to most people. And you can get that if you aggregate all the dementia costs into one bucket and you say, okay, I'm going to care and manage them through a program that, could be a guide type program. We learned about the guide model, why it was launched, right? That it's really intended to bend the cost curve. By the way, I didn't say this, but it's an 8-year model. So it's a fairly long model. One of the goals really is to bend the cost curve and to show that you can keep people out of skilled nursing facilities, which are huge cost centers for states and the federal government. It's also sending a clear signal to everybody that dementia is a national priority. So certainly health plans are looking at this differently. We talked about this multiplier effect, right, which I think is really important, and that it's really driven by the patient's inability to self-manage. We are suggesting that people with dementia be managed in a specialized program, the same way you might look at kidney care or other conditions. We talked about hospitalizations being the key driver, and we talked about detecting a change in condition being one of the most important things you can do. And then everybody sort of echoed that the family caregiver is well positioned, better than almost anybody else, to detect that change in condition. And then Nicole shared how throughout in the case of Seresti, through a tablet-based approach that comprises personalized education and coaching by a social worker, and by asking the caregiver, once they trust us, to share what they observe, that we can tease out those instances where there's a change in condition, and then we can lean on primary care to address it. And we also talked about how that approach really unburdens the primary care physician with all the non-medical stuff is handled by Seresti, all the psychosocial challenges, all the things that we can coach and educate around, so that the office takes fewer calls and the primary care physician is really focused on medical issues, right? To make the encounter of a really complex population more effective. And then we looked at the ACO implications, saying, for an ACO, the fact that you could achieve shared savings and not have to pay anything, right, is exciting. And then, of course, recognizing that the cost savings have to be larger than the guide medical expenditures, right? So if you save no money, it would actually hurt you. So partnering with somebody who can save you money is important, because otherwise your patients could be, aligned with or enrolled by any guide provider, right? Every state, I think, has providers in guide. I think Florida has quite a few. So any one of your patients could be, enrolled by another guide provider, and then their medical expenditures count against you. And unless that model of care can save money, right, it could actually hurt you. So doing nothing here is not free for an ACO. That was largely what we talked about. So I think we've got about 9-10 minutes. So maybe Samantha, you can just start feeding us some questions, and we'll dive in.
Yeah, sure. One of the questions we had today is CMS fee-for-service model in past have reduced payment for mental health conditions for patients treated in PCP office. Is that fee-for-service reduction lifted with the sharper focus on risk and cost for behavioral health? It's a two-part question, so I'll stop there and let you answer that part first.
John, did you get that by chance?
Yeah, I had, I've been reading it, trying to make sure that we address the question here. So I think the writer is talking about phenomena in fee-for-service where PCPs are not incented to take care of this population or any mental health conditions for that matter. And, asking whether, programs like Guide makes a difference in that, because currently they're dissuaded to see from these people, as the questioner says. Yeah, if I had, a couple maybe overreactions to this, but if I could get rid of the fee-for-service system tomorrow, I would. And particularly, I'm a PCP, so full disclosure, that was my history. I love my specialty colleagues, but it really pivots. And the irony here is, of course, CMS has all that rhetoric too, right? That, PCP is important and we're trying to help them. I think they're actually putting, their foot forward on this, on the guide program. So they're it's got to be a value-based organization. So they're not changing the standard fee-for-service system. So if you're in an ACO, and that's the audience, then you have the opportunity to leverage the alignment that Dirk was referring to on the payment side, because you do get paid for the overall management of these people. And probably even more importantly than that initial payment is the savings opportunity. It enables it, because you can't replicate the VA clinic that I did 10 years or a number of years ago. You can't do that. I do think that the payment is really important here. And I think, as you heard Nicole say, the PCP is still very central to the outcomes here. We're not going to call the neurologist with the UTI. That would be counterproductive. I don't think the neurologist would want to field those calls. And then, so the way we try to do that is shape the caregiver's conversation, give them some benefit of some help and some experience. I deal with a lot of things up front, but the ones that do need to go in, they're just better tuned to have that conversation and get the result they need. So we need the PCP and the guide programs in an attempt to align payment on that. That's the best I can answer that, I think.
Yeah, terrific. Samantha, is there another question?
Yeah, there was. You had another question. Daria was asking, or basically stating, supports beneficiary outcomes and assists caregivers with education and assisting patients with quality of life patients may not otherwise experience. So I think she was actually just saying, great point there. Somebody wrote in that, as an FYI, CMS is allowing the guide program participants to allow to also build a BHI program, which is a CMS care management program. Can you reiterate how ACOs can be financially penalized if they do not align with a guide partner?
Yeah, this is, we actually, if you go to our website, there's a little article that somebody in our team wrote about, I think we said doing nothing is not free. So think about it this way. If you do nothing, your patient could align, all right, or join another guide participant. And then those costs add to your medical expenditures. So let's suppose it's $2,000 of guide payments per year. If you are, if you achieve no cost savings, that $2,000 get added to your expenditure. And then if you're taking 30% downside risk, right, you're writing a check to CMS for $600, 30% of $2,000, right, for that patient. So that kind of hurts you. And some people look at that and say, this is why I don't even want to participate in guide, because the medical expenditures are negative. So yes, if somebody aligns your patient with a guide provider who can't save money, you're writing a check to CMS. So that's the risk. And we've talked about a model of care that detects a changing condition in the home. That's very unique. We think Suresti may be the only company that has a proven track record of being able to do that. So we actually guarantee that our cost savings, which are in the $7,000 to $8,000 per patient per year range, are much larger than the $2,000 guide payment. So you look at that net, 8,000 versus 2,000, 6,000, net, and then if you get to keep 50% of that, right, that's a significant amount of money per patient. The other thing I would say, if it hasn't been asked, right, the enrollment is a big deal. So Suresti takes that on, right? It's no lift for the ACO. We get CCLF files, we identify patients. We have in Medicare Advantage for many, many decades, years, not decades, for many years, proven that we can get people enrolled in the program. So there's actually no lift, right? So at some level, it's like, no lift required, unburden the PCP, you get shared savings. There's a guarantee that there's no downside risk. And by the way, if you do nothing, there is some risk, right? So I think, we would say there's a strong case for at least having a conversation to learn more. And, if you are interested, right, we can, in a 30-minute call, collect enough information to make a proposal to you. We have done this for so many years that we have some rules of thumb about prevalence and costs that will allow us to get, a financial proposal to any organization fairly quickly. Okay, that was a little bit of a commercial there, but Samantha, keep going with the questions here.
It looks like some of the other ones were just statements that people had just broke down. So I think that wraps us up on the questions from our audience today.
Okay, terrific. Any final comments from John or Bart?
Yeah, I had one last comment. There are clinics out there doing care for dementia patients, so they're being seen. One of the things that you triggered in thinking about this, Dirk, is if you decided, and we all think you should, your ACO should get involved as this rare new opportunity to do this. Look at the different models out there. I think the clinic-based models are going to struggle, and this is what we're hearing. They have capacity constraints, they have geographic constraints, and they probably aren't. They're waiting for referrals as opposed to doing proactive outreach for enrollment. And I think those are three key factors. If you really want to get a robust program, you've got to have the upfront enrollment. So that was a good pointer. Just wanted to comment on that.
Yeah. Nicole or Bart, any final comments?
Yeah, I think that the thing to remember is this is a unique opportunity to address a new population of patients, to improve care, improve outcomes, and create savings. And with, as you mentioned, the guide model, it reemphasizes why we should be doing this, but doing it with a provider who has a proven track record, so you can get true savings and not have it cost you money in your ACO. We want the ACOs to be successful, and this is a great opportunity for the ACO to be more successful than it would have been otherwise.
Nicole, anything to wrap up?
No, just remember the power of those family caregivers who really want to help They have a lot to give and a lot to do.
Yeah. Okay, well, this has been terrific. Thank you to the panelists. Thank you to the Flat Coast organization for allowing us to present this information. I think there's some contact information, that's in the deck. I think Samantha and team will follow up with the webinar and so forth. So again, thank you for taking your time. Thanks for the great questions, and I appreciate the great discussion. Have a wonderful rest of your day.
Thank you, everybody.
Yes, thank you, Dirk.
Okay.
Thank you.
Bye.
Bye.